morning, everyone. I'd like to call this meeting of the Bellingham City Council Public Works Public Safety Committee to order. We have two items on our agenda today. The first is a bid award for scrum concentrator replacement at Post Point Water Treatment Plant. Ted?
Yeah, good morning. Ted Carlson, Public Works Department. This piece of equipment is part of the solids handling process at Post Point, removes fats, oils, and grease prior to primary treatment, and then sends that over to solids handling. The piece of equipment has been in place since 1974, so it had a 30-year estimated useful life, and we got 40 years out of it. It was within the budget. We budgeted for replacement this year. Engineering estimate was slightly more than the bid. Apparent low bidder is for award, or lowest responsive and responsible bidder was from award contractors in Ferndale, and staff recommends approving to the low bidder.
Michael?
I move that we recommend approval of the bid.
Yes, Roxy?
I'm happy to help get scum out of our community.
Oh, yes, Michael.
I know that when we replaced some of the other big equipment at the Post Point treatment plant a couple years ago, we found motors that were more energy efficient but also equally powerful. I'm just wondering if there's any energy savings in this. I have no idea how much energy this particular thing uses, but is it any more energy efficient than what it's replacing? You want to come down? Yeah, I'll ask Rob Johnson to come down. He's a plant superintendent. I'm just hoping in 40 years maybe the technology has improved.
Yeah, hi.
I say this with a mind to the Georgetown University Energy Prize, where we're trying to reduce municipal consumption of energies, and a lot of what we spend our energy on is some of these big, heavy pump stations and equipment. So I'm just wondering about this one.
Yeah, I'm Robert Johnson, plant superintendent. I think there's a 5-horse motor on this piece of equipment. It's very similar to the last one, so it's a very low energy use to begin with. We will be running the scraper arm on a VFD, which takes advantage of starting and stopping at lower current.
It's a variable frequency drive. It helps save energy.
But it's like a pretty small piece of equipment.
Yeah, it's very small as far as energy consumption.
Okay. Anything else? Okay, we have a motion before us. All those in favor of recommending approval tonight, answer aye.
Aye.
Hi.
Okay, we will recommend that to the full council tonight. Thanks. The next item is one I'm really looking forward to hearing about. It's the Community Paramedic Pilot Program Evaluation. Chief.
Good morning, Bill Newbold, Fire Department, and appreciate the opportunity this morning to present to you some of the data that we've collected during the 9-month program that we started back in October. And this is the third time that we've been presenting to council here. Our first time was in October of last year, when EMS Captain Sean Ferdinand gave an overview of what our pilot program would be for community paramedic here in Bellingham. And he also described what was some of our desired measurables that we wanted to track during the 9-month program to ultimately be able to evaluate its success. And then in January, we had paramedic Rob Stevenson, who's also here today. He is functioning as our community paramedic out in the Bellingham community. He spoke to you in January and then also presented the video that IT helped us develop that's running on BTV10, which gave a really good overview of the program. Today being our third time in front of council, what we wanted to do now is to present the data that we've been collecting, which effectively evaluates the program that we've been running. This started in October of last year, so we're not yet completed with the 9 months. We wanted to come before council with some of the data that we've collected so that we'll have a decision in place by the conclusion, which will be at the end of June. So with that information, I'd like to now introduce Assistant Chief Rob Kinzel, who will give you a little bit of background as we begin the presentation.
Thank you.
Good morning, Rob Kinzel, Bellingham Fire. It's a good thing that I only have 2 slides because I can be a long storyteller, and I know you're limited on time here, so I'll try and keep it short and sweet. But the background really is important to, let us know where we're moving. So As you know, we just recently celebrated our 40th anniversary for our ALS care provision here in Whatcom County. And, you know, we were at the forefront of providing ALS care nationwide at that point in time. And as we have gone along, we have, you know, taken on responsibilities of BLS care as well and started transport, you know, circa 2005 with that, and we've just been increasing our responsibilities over the years, increasing our call volume, adapting and changing as needed, and now we're taking another step in adapting and changing and seeing a need, and all the while trying to provide our core mission, which is fire suppression and EMS care as well. And so we have had anecdotal evidence over the years, you know, where we could say, you know, I think we're starting to see this same person over and over, or we're starting to see a group of people who really need our care, but it's not really the care that we typically provide, or, you know, that we're used to, or that even would be most beneficial for us to provide. So we had, you know, Captain Farnan come upon an idea that really is sweeping the nation. I just came back from the National Fire Academy and had an opportunity to run into scores of other departments who are trying to get ahead of the game and do what we are already doing right now. And so he brought this program forward, and we have, as Chief was saying, had an opportunity to try and analyze the results that we've had with it. And so, can you go to the next slide there, Rob? So what has happened is that, yes, we have recognized that we do have these frequent EMS utilizers, and that it's starting to stress our EMS response system. Like I said, we're not just here to respond for EMS. We also do fire suppression, and every call that we go out and we're not available to respond to another is, you know, is a call that we're not able to serve somebody. So we are trying to find a way that we can make ourselves available for, you know, our core mission, those really high acuity type calls. So we've landed on this EMS paramedic idea, which is fantastic and wonderful, and all these people behind who are going to, you know, proudly support the great work of Rob Stevenson here, because our crews are at the forefront of these emergencies. They see what people's needs are. They're able to plug them in, you know, to Rob and to these other agencies where they can get better care, improved care with better health outcomes. And, you know, we aim to show you at a reduced cost as well. So go ahead, Rob, with the next one.
Next slide.
Next slide. So with that, we have been collecting data for a period of time now, and Ryan and Rob will speak to that in just a second, but I'm just going to give you a brief overview of what we've collected here. So Ryan has volunteered his time and helped us figure out that, you know, of all of the responses that we go on in a year, which is, if you see at the lower right-hand side, there are about 12,500 calls over the course of a year. Sometimes 46.5% of those are multiple users. They've called more than one time for our help. And, you know, that is absolutely going to happen. People do tend to have, you know, an emergency that doesn't get solved right away. They need more help later on, you know, a month, 2 months, 3 months, whatever, later on. And we absolutely understand that. But in tracking this, what we found is that 200 high utilizers, which we're calling someone who has called us 5 times in a year, that gets, you know, that's something that raises an eyebrow. And then 30 people who have called us 10 times in a year. At some point in time, you start to understand that this is no longer acute care and that this is chronic care, and that really they're having issues with managing their health. And so we understand and recognize that we don't really do chronic care, we do emergent acute care. And so there's got to be a better way for us to do this. And so we're trying this pilot project out, and we're really excited to present the data that we've collected for you.
Thank you.
My name is Rob Stevenson. I've been a paramedic and a firefighter and paramedic here with Bellingham for 23 years. In our community, this project improves the lives of Sorry, I'm going to read this because otherwise I'll start rambling and probably go too long. It improves the lives of our most in-need population, saves time for our existing fire and medic crews, and reduce the costs of our healthcare system overall. I've worked with over 100 patients to date since October 1, and building trust with these individuals who usually feel underserved is very important and is best done in person. I think that being able to get out there and see these people in their own homes and talk to them and communicate with them in person is different than phone calls. It's different than our system has been built to do before, and offers a level of care that most of these people have never felt or had, that they feel certainly more cared for. So let me go to the next slide here. This is what my referral process looks like. Typically, I get referrals from the paramedics or the engine company captains. They let me know who is calling 911 frequently and or someone that's just started to call 911 frequently and has some needs in their home that they obviously recognize as someone that's going to be calling more often. And then we also are able to look at our existing call volume that comes in through medical reports and query how many people are calling and repeat callers, and I then look into that situation too. And then partner organizations. We have Northwest Regional Council here, WAHA here, and Opportunity Council. They are agencies that are, and Interfaith and CMAR, they're able to call me if they have welfare checks, or call me if they have people they're concerned about, and then I'm able to go out, check on them, and then try to define what their needs are. So I review the case. I then call, but again, like, calling just doesn't seem very effective. People don't answer their voicemails, or they don't have phones, so I have to go visit them in their home, determine the situation, and then I don't see myself as trying to be their primary care at all. What I'm trying to do is connect them to the agencies that exist already in our community and get them to get better care so that they don't need to call us and access 911 so often. And then sometimes on occasion I am able to give these people rides to either their own doctor or to get medications. So I do have the ability in my minivan to give them non-emergency rides. So if you look at my visit time, that pie chart up there, you'll see that most of my time is spent visiting, and then the big part of my time is all about connecting to the.
Rob, Roxanne had a question, if that's okay.
Just interested in understanding, how do you deal with it when somebody doesn't have a physical address?
That's tough. The homeless part is very tough. So right now, we have, through Opportunity Council, we are working with the homeless outreach team, and between the homeless outreach team and the police, they are the two most reliable sources to know where someone hangs out and to be able to find them. I've tried to set appointments, meet me in Cornwall Park at a certain time, and it's failed. I've also had appointments that I set up for people, and they're just sure they're going to make it to WAHA, and they don't, you know. And so it's because a lot of these folks have significant, you know, substance abuse problems, mental health issues, and so then they don't sometimes make it to appointments. That's why the visit is so important, and connecting them physically myself is what I think is most effective, is kind of keeping close tabs and working with them.
Thank you.
So here's some of the agencies that I connect with. We have substance abuse folks, mental health and counseling, housing, homeless services, health resources, and then senior and disability resources. Now, there are a number of these resources. I wish all these resources had more resources, because I am able to refer and get a lot of help from these folks, but sometimes there just is not enough, quick enough help for some of the people that I'd like to get help to fast, but it takes a while. This process does. Here's an example. I just want to show you this slide. I'm going to show a few more like it. This is an example slide to just show you what it looks like as we, this would be the perfect scenario of me visiting someone and then having no further 911 calls after that. But you'll see the red dots represent, on the left there, represent 911 calls when someone calls us. And then we have a a point at which we call like day 0 when I intervene, where I try to either visit or refer them to someone, and then after that I'm hopeful that we're able to figure out their situation, get them plugged into the right service, and then reduce their need for us. So as you see the timeline 0 there, we get a phone call or and then a couple of visits after that, and this perfect scenario would be someone that no longer calls after that. Next one. So here's a person that I visited, just an example, 61-year-old female. She has significant cardiac issues. She's to the point where her doctors told her there's nothing else they can do to help with her heart. So unfortunately, she still suffers from significant chest pain and calls 911 frequently. And so as you look at the minus 250 there on the left, that represents 250 days before I visited with her, and all the 911 calls that she had. I did a case review, and then visited her, and then did a couple of case reviews after that. And you could see that she still has, significant cardiac issues, so still has called 911, has still accessed 911. But we had 15 calls for the 7 months prior to seeing her, and then only 4 911 responses after. And so that was a fair success. I've got another slide that represents her again, and it just shows a 4-year history of her calls to 911 in this slide. And you could see, I'd like to point out that towards the beginning of her calling 911, there's the kind of occasional calls, and then there's a point where someone gets to calling us more or less for their primary care. So their own system that's in place, whether it's their own primary doctor, they're unable to really manage them well enough, or for whatever reason, they start using us as primary care and the emergency room. And that's an example of how this flows here. So after seeing her, if we can imagine 4 years post, we hopefully will still continue to reduce the overall load to the emergency room and to the 911 system, which would save significant costs. This patient here, we have a 67-year-old male, mental health and medication compliance problems. He's not very good at taking his medications, and I referred him to WAHA, and we were able to basically reduce him down to no 911 calls after seeing him. I need to point out on this slide how we have some 911 responses, and then it looks like right before I start seeing him, he doesn't actually have that many 911 responses. But that is related to the fact that our tracking system that we have at the fire department, it tracks medical reports really well. But when the guys go out on the engine company and see someone and they deem it not to be a medical call, they might see someone for helping lift them up off the ground. They won't fill out a medical report, but they would still refer to me because they're seeing this guy all the time. And so unfortunately it doesn't show on my chart very well. There are additional 911 responses that are occurring here that are also taking time that don't, thank you, that don't have, that don't necessarily show. So let's see. After case review, WAHA started working with them. We got, okay. So this is the person that WAHA, we went down to meet the governor with on our little deal. We went down to Mount Vernon and met with this particular patient. So nice little success there. Let's see. Patient number 3 here. This person, it took a long time to kind of figure out how to best help him. Just like so many of our patients, again, you have this void of no calls right here. And again, that's just not showing in the data because of our system, the way it's set up. But he was calling a number of times to 911. It took, you could see how many visits I have with him. So how intense the kind of additional visits that I saw for him were. That is related to the fact that he's got significant medical problems, and his ongoing needs were great, and WAHA was able to plug him into a doctor at Interfaith and follow him to all of his appointments and help him, but he would call me frequently, and I actually went out and did some kind of primary treatment with him to keep him from going to the emergency room and calling 911. He's now down in a care facility at Whidbey Island. So we've It took a while, but we've gotten to the point where he now is getting significantly better care and is happy to be with people. He's a real social guy, so that's a success for us there. Patient number four, this is like just a homeless outreach situation here. We have 56-year-old male, mental health, substance abuse, and homelessness. And again, that void kind of right before, you know, that he was still calling 911, but the guys just weren't writing medical reports because he didn't seem medical at that point. But he is a person who, with intensive kind of mental health services, were able to reduce his need for 911, but he's still on the street right now. He has significant barriers to being housed because of kind of destroying all the places he's in because of his mental illness, and getting medications is difficult, and that's getting ironed out, so he's getting help. But some of these aren't kind of quick fixes. They're especially in the homeless situation, because housing is difficult to get for people. Let's see. Is this you? All right. So leave that there for you.
Hi, so I was, let's go back. I was challenged with the task of evaluating the community paramedic program. And so we collected some data and analyzed the data so we could look at not just the individual patients, which is important because it's intensive case management, but also look at the whole picture. The main question to ask was, what is the change in 911 EMS utilization after the community paramedic begins to work with the patient? And this question was the right question to ask because it addresses the three aims in health services. Does it improve healthcare quality? Does it improve population health outcomes? And does it reduce cost?
Excuse me. Can I get you to give
Sorry.
your name and title just for the...
My name is Ryan Moore,
Okay.
and I'm volunteering
Yeah.
I volunteered to do the analytics for the.
Okay, thanks. I just
Yeah.
wanted to get it on
Okay.
tape. Yeah, thanks.
At any rate, so when somebody calls 911, and nothing against the EMS crews, they are out there and they get there quickly, they respond quickly, and they are courteous, and they provide excellent quality care. But when there's a chronic patient that needs care in the hospital or care, more primary care, then calling 911 is not the highest quality care that they can receive. And then also in terms of population outcomes, health outcomes, when somebody calls 911, it's an emergency. And if anybody's ever called 911 for an emergency, it's a big deal. So if we reduce the number of calls to 911 or the number of EMS responses, then we have improved the health outcomes of those patients. And then we all know that emergency, or providing emergency response, when somebody responds, or when EMS responds, they respond with an engine, and they respond with a medic unit, and so it is very expensive primary health care. So, so we collected data over say, a 6-month period up until April 7th, and the enrollment criteria was to go through the 911 records, search the medical records, and find patients that were chronic cases and intended to call 911 often, the patients like Rob just mentioned, and to contact those patients and help remediate the chronic calling. A second referral was, as Rob mentioned, was from EMS crew, and this is more of a preventative measure. It's not necessarily somebody who calls chronically, and it could be somebody who had an acute incident, but they're recognized by EMS crew as a high risk of calling 911 in the future. So that's a preventative measure. But in terms of analysis, we considered the intervention day, that was the line on the previous graphs, if the community paramedic Rob calls, visits, or assists or connects the patient. So had the first point of contact. So during the 6-month period, Rob enrolled 92 patients. and 51 of them were male and 41 were female. The males had a median age of about mid-50s, and then the females about 60. So in order to analyze the community paramedic program's impact, we collected 6 months of data, and we're continually collecting data, but this is where we put a stop point and started analyzing it. We wanted to do within subject analysis. We wanted to look at every individual patient and look at, what was the utilization prior to Rob's intervention versus after Rob's intervention. And so that required 3 months of post-intervention time in order to have that data to compare. So that allowed us to analyze 48 patients enrolled during that first 3 months. So this, to better describe that, if the first patient was enrolled at the start of the program, the second patient gets enrolled soon after, and then after that, and after that. And so the last patient that we could analyze was enrolled at the beginning of January because we needed that following 3 months, right? So then we lined up all of the intervention days so we could get a good count of what the 911 utilization was before versus after. And those are all examples, but here's the real data. So the red on the left is 12 weeks prior to intervention, and the blue on the right is 12 weeks after intervention. And you can see that there's definitely a drop on average in the post-intervention weeks in the number of 911 calls from the 48 patients. I'll reiterate this over and over again, this is only the first 3 months of enrolled patients. So, the program in its infancy is seeing these kinds of results. So you're probably going to ask about the spike right here, okay, right before the intervention. And the reason for that spike is based on the enrollment criteria. So remember that the EMS crew refer the patients to Rob. And so it's highly likely that on that week prior to the intervention, they had called 911. So that's what that spike is there. So if we collapse those, this is the actual count of pre-intervention versus post-intervention. ALS means advanced life support, and BLS means basic life support. And there was a reduction of 80 calls during that, or 80 responses. When I say call, it's the full response. Yeah. So it's everybody going, not everybody, but it's an engine unit and a medic unit going out to the patient and addressing their needs. So 80 fewer calls, or a 61% reduction. And again, that's just 48 patients during the first 3 months. We wanted to look at, make sure that this just wasn't one extremely high utilizer that just stopped calling. So we looked at it among individuals to see that there was, in fact, a reduction for each individual. And 31, or 65% of the individuals did show a reduction in utilization. 13 had no change, and 4 had an increased utilization. So we don't have a perfect record, but I can give some idea as to why there was an increase for some of the patients. Again, these patients they have a chronic medical issue, and they're usually deteriorating in health. So you would see a natural increase in utilization, but I suspect that this is lower than it would have been if there had been no community paramedic intervention. In fact, I'm fairly certain. Another possible reason is it takes time. It takes time to get these patients connected to the care that they need and connected to the community health resources that we have available to them. Rob gave an example of a patient that took over about 5 months. Yeah. Took about 5 months to get into an assisted living facility. So that patient could have potentially been in this red area, but now is no longer calling 911 after 5 months. Mm-hmm. Okay. This shows a reduction in ED transports 3 months prior to 3 months post. And so there were 50 fewer ED visits. If a patient is transported, they're transported to the ED in Whatcom County. And so this shows that reduction. The AHRQ, American Health Care Research and Quality Organization, found that the average ED visit for a person in poor health is $1,500. So 50 fewer ED visits.
When you say ED, do you mean like ER?
Yeah, sorry.
Thank you.
Emergency department, yeah.
Great.
Yeah. So 50 fewer ED visits amounts to $75,000, and that's just savings, to the ED, or and doesn't include the savings for the city. So we wanted to take a look at also what types of people are calling 911 for these chronic issues, and roughly half of the 92 patients during the 6 months had a mental health issue, and about a third substance abuse, and about a quarter mobility and falls, homelessness, and chronic medical issues like diabetes. One of the main reasons that I wanted to show this slide, though, also is to again reiterate that these are real emergencies. When they call 911, and they're not just calling 911 frivolously, they actually have an emergency, but these emergencies are preventable because they're related to a chronic health issue or a social issue that they need resolved and can get resolved by all of the community health and social services that we have. So this is showing the reduction within each of these specific groups. And a reason for this is continuous program evaluation. We wanted to make sure that there was a reduction in all of these groups. If there wasn't, we could look at improving the program and figuring out why a specific group's needs aren't being met. But we found that it was about the same reduction in every group. And if you're looking at why the numbers don't add up, it's because some of the individuals could be in multiple groups. This particular graph shows among the 92 patients over the 6 months, how many times Rob worked with one of the organizations in our community to help this patient. This is really important because, again, the program is in its infancy, but it's already developed all of these relationships in the community to help get patients connected to the care that they need. And I think that's it on the data.
Thank you, Ryan. So I should introduce Ryan to begin with. Ryan is our analyst. He's been volunteering, and we also have Mallory, who is Dudley, who's been working with us from internship from Western Human Services Program. She's in. Thank you. I'm going to read something again real quick. So when I started, it was difficult for me to find the right services for each patient. I can't imagine how difficult it is for the average citizen to navigate on their own in their time of need. I'm amazed at how many caring, hardworking advocates are managing the day-in, day-out difficulties for our vulnerable community members. I've learned about agencies that help people with disabilities, medical problems, mental health, meals, shelter, clothes, free showers, free laundry, and housing. So we have tremendous services in our community, and connecting people to those is exactly what I'm doing. One misstep is all it takes for a care plan to fall apart. And some of those missteps are things like a missed appointment, a missed phone call, a missed medication pickup at the pharmacy. Maybe the person has poor communication skills and isn't able to advocate for themselves with their own doctor very well. So I make sure these people don't continue to fall through the cracks. And I see that as my job, which ultimately reduces 911 calls. They're difficult to help sometimes. So many of them have lost trust, they've lost hope, and lack the motivation to care about their own health and well-being. I have the opportunity to spend more time exploring and understanding their needs than the medic units and fire engine companies can. There are gaps and challenges that our frequent utilizers face, like transportation, disabilities, failing health, falls, homelessness, no medications, no doctor, no drug or alcohol treatment, no assisted living rooms available in our community. There are a lot of different barriers out there for people. Life is difficult and painful for this population frequently. I feel proud to be part of the Bellingham's plan to connect people to these most basic human services. We are creating hope and making incredible, life-changing differences in many of our community members' lives as we do this work. I'm going to share one brief story with you guys. I had a person that I was working with Jaylin from Waha, and he died about 4 weeks ago now. He's a 68-year-old male with pancreatic cancer. He was just an avid researcher about his medical problem, did not want to die from cancer, and was just fighting right up till the end. But because of the cancer and his treatment, he suffered from significant pain and was calling 911 frequently. And so I got connected with him because the engine companies referred me, and then I was able to connect him with Waha, and we basically stopped all further 911 calls. But during that time, we were able to get better communication with the cancer doctors, better communication with his own caregivers, and get him to appointments, listen to him call us instead of 911 when he was in crisis, and kind of work out how to better manage his pain. And ultimately, he was able to go on a train trip that he really wanted to go on back east before he got really, really sick. And so that was a neat thing for him. He just loved trains. So let me think here. Let's see. Finally, he ended up in hospice and passed away in their care at hospice. So it was ultimately a nice, peaceful kind of way for him to go. But he was just fighting up till the end and really had a hard time coming to terms with that. But ultimately, very, very peaceful, very nice for him. He loved trains. He kind of lacked a local family support, and I think that's a common theme. If you look at the people that utilize us frequently, they frequently don't have local family, don't have the support around them that we kind of fill in and offer for them as a community. So we went down Friday and took his ashes and had a little ceremony, and actually spread his ashes down by Chuckanut there on the tracks, which is what he wanted us to do. So that's just a little story about one of the cases that we deal with, and I just wanted to illustrate how much people don't necessarily have support, and that's part of their reason for frequent utilization in 911, in addition to mental health and health problems. Any questions?
Michael?
Oh, I'm sorry, I'm not done yet.
Okay.
I have more. I'm getting ahead of myself. Just a little slide I got up here right now. It just points out the fact that over the years, fire departments, through the 911 system, we've allowed people to kind of define their own emergencies. And it has to do with people calling 911, and we go out and we respond to just about everything that they call in for. And some of these emergencies, 70 to 80% of them are not life-threatening, but yet we still respond. And that part of our system has continued to grow, and it's taxing our system as we see it. So reducing that kind of frequent utilization by things that aren't necessarily true 911 emergencies is going to help save costs and time. And we have just 230 community paramedic programs in the nation right now, and that is growing because they see it's a way to save money and save time for resources. Let's see, there's other ones. I just wanted to point out that there's regional programs right now in our own area. Snohomish has one going, and I've got a call from Everett Fire last week, and a call from Whidbey Island also asking about our community paramedic program last week too. Dallas, Texas, Fort Worth, Texas have big numbers. They've been doing this for a little while down there. And then internationally we have London with a big program, and they have a little bit higher cost, they say, for their emergency room usage. So their savings is also significant when we reduce the call volume for those folks. Outcomes, ultimately better patient care, increased availability of our existing resources, and I think that's key. We have 6 fire engines in the city that run aid cars with each one of those. They also go out of service off their engine to get onto an aid car when a basic life support call comes in, and then we have 4 medic units total in our county that are serving the population. If we could save and reduce calls, we will significantly make them more available. And then the evolving community collaboration, my ability to figure out who's out there helping these folks already and plug them in is a significant piece of this whole reduction here. Now questions.
Michael?
Rob and Bill, thank you very much. These are great results. I do want to say one thing. You were talking about how there's a lot of people people define their own emergencies and they call us. We don't want to send the message, don't call 911. That is the number we drive everyone to for all their emergent or needs they even think might be emergent. Go ahead and still call 911. This really has to do when we've identified that people are calling 911, as you said, for legitimate emergent reasons, but we can intervene. So it wasn't that the call was inappropriate, it's just that there maybe is a better response to reduce the calls. I have background in scientific training, and Ryan, some really important things I think to with regard to your data. Yep. Using a point-in-time selection,
right?
People are going to be going up and down, up and down. Absolutely. If you always pick people at a high point, it may be that they would naturally drop. So you're doing a within subjects comparison rather than with a control group. With other groups. So I think that leads to an automatic overestimation of the benefit. I think there's a really easy solution by creating a quasi-control group, going back to retrospective data and picking someone as if we did have a community paramedic program and kind of inventing a comparison group.
Right. Yeah, and to be able to measure with a control group would be ideal. A randomized control trial would be the ultimate best.
Right, but I'm saying you can create a quasi-control group by imagining 2 years ago if we had the program and picked those people. It's difficult. I'm just thinking that I have no doubt there's enormous benefits. I wouldn't lean on the number too heavily.
Right.
It's good, but I don't know how good.
Roxanne?
Well, as someone who just got back from Fire Ops 101 in Richland, I learned so much, and it was really eye-opening for me to develop a better understanding of what EMS professionals go through. And it's going to get interesting as time marches on, as the technology improves, as the medicine improves. And I worry about there being a perception that our paramedics and EMS service providers can just do it all. And so that's why I really, for many reasons, support exactly what's going on here, so we can get the chronic people that chronically call to the right form of care, so it's not all the burden on our fire department.
The service area for the program, was this limited to the city, calls within the city, or?
It was almost. But because we respond into the county as well, there was a few patients that I did deal with in the county too, because Medic 10 in particular was responding to them. There's a few patients that were high utilizers that were in Medic 45's territory, and I was able to communicate with their supervisor and kind of pass those patients to Jerry Martin. So the primary focus, though, was definitely in the city. And because of our services here and the homeless population here, we tend to have a heavier need here anyway. We do.
Right.
Yeah.
Okay, I was just wondering, because I know as we go forward, we're looking at EMS levy, funding, other kinds of things. As we see the continued data coming out of this, it's something I want us to see. Would it pay to roll funding for this kind of program into our overall EMS levy program on a county level as a project that may reduce the need for calls?
I would sure think so.
Yeah, and so, that's something that's sitting on that board, it's kind of rolling around in my mind, is seeing these kind of results and knowing ahead of time pretty much that what we would see, these kind of results and the results from that, I think what we'll see from WAHA with their case management program that we had taken, that was taken to EMS program to look at, that I think we're going to see that continued results. And I think, if we see that, this is the best place to spend resources. in reducing those kind of calls instead of those expensive $1,500 a shot call. So I'm really excited to see these results. I know we were really anticipating seeing this, that kind of thing, and I just want to say great job, and I look forward to seeing the final reports on this, and looking forward to being able to recommend continue funding for this program, because I think this is going to really prove to be a real valuable program for the community.
Thank you very much.
Yes.
That brings up a point. Oh, sorry, Chief. I didn't mention that the state legislation has allowed us to do this work now. So in June and July, it'll be, I think, all the way past, which this community paramedic work will have the potential for some cost recovery. So the ability to bill for some of these services in that we go out and do evaluations, do some kind of connecting of care, we can ultimately have the ability to recover some of the costs of it. So that should be coming up. And a lot of the other programs here in the state are a bit ahead of us on that, especially Snow One, on figuring out those very things. And we'll be able to get their help on understanding how to pursue billing and some cost recovery.
Great. Chief.
Thank you, Terry. You just gave me a great segue into sharing with you a couple items and then wrapping up here. And again, the focus of the community paramedic program overall has been to improve patient outcomes, and that's connecting the folks in our community with the appropriate resources. And by doing that, really the outcome for us as a city and the other responders is by building system capacity. And what that does is, as we are not responding to the high utilization with our engine companies and our BLS companies, that builds capacity within our current system within the city of Bellingham to better utilize and more appropriately utilize our resources for the types of emergencies that are still going to be coming over the 911 system. And so improved patient outcomes and a more appropriate utilization of our resources ultimately build system capacity within the city and our EMS system. Would like to just say thanks to a number of people who have shown support and interest in this, Mayor Kelly, council members as well, and also our partners in the community who have the services that we are working collectively with. And so really extend our thanks to them. And then thirdly, our next step is to be back in front of you in June, in which we will bring forward a proposal. And based on this data, it's our expectation to bring together a proposal for you to consider full implementation and continuation of the program as a permanent position and program. That's all I have.
Okay. Anything else? Okay. Seeing nothing. That's our last committee report. We're adjourned.